Well, welcome everyone to what promises to be a compelling close to the second edition of TIO USA 2026. Hemodynamic support has transformed how we approach high-risk PCI and cardiogenic shock, but with expanding options comes the challenge of knowing when to use and how to escalate and how to wean these devices. This session tackles all of these hard questions head on. And joining me are really, really good friends and colleagues, Barbara Basir from Detroit, Nadia Sutton from Nashville, Alexander Truesdale from Virginia, and Sunil Rao from NYU here in New York. Let's open with an evidence update, look at how the guidelines in this space have evolved. You'll have to suffer through another presentation by me, but I actually will try to keep it more clinical because I think that's what's most relevant, and then hopefully open some time for discussion with regards to the concepts that I'm going to broach. To start, I've titled this Integrating Hemodynamic Support into Daily Practice, and what I'd like to show is at least the way I like to think through these cases. And everything is going to be patient-oriented, obviously informed by the data. But one question I'll just posit is, this is a lesion, this lesion's in the LAD, and the question is this patient in danger during an IVUS or a PCI? Well, the anatomy may be one thing, but what's the clinical scenario under which this anatomy prevents? And it's one where the patient presented with non-STEMI and had shock initially with a balloon pump, had an EF of 20 and occluded right, an episode of VT, and an ischemic LAD territory. So she came back to the lab for just imaging and potential PCI of the LAD. And during this imaging and PCI, not guided by right heart cath, just come down to the lab, what the patient actually had is some desaturations. And because of the underlying substrate and how high risk the patient was, unfortunately, that was not well tolerated. And what the patient ended up having is a significant amount of VT that then went into VF. She had to be put on full hemodynamic support, had CPR, had both Impella and ECMO, and ultimately left the hospital 3 weeks later, but had a whole bunch of sequelae of this. And this is an example of why the baseline hemodynamics, not just the anatomy, are so essential to the treatment of and management of patients that are presenting to us in the cath lab. So why is hemodynamics such an important concept in complex PCI? Well, first, it's because the things we do obviously make patients worse. Catheters obstruct native flow. Contrary to popular belief, does not contain hemoglobin and can depress LV function. And balloon stents and adjunctive devices all produce ischemia while we work. And so if you have bad hemodynamics starting into the case, these things will make the patients even more worse, and they just don't tend to tolerate those things as you proceed in your intervention. And so avoid hemodynamics and ignore them at your own peril. So here's another patient, has prior bypass surgery, a calcified RCA. The grafts to the left side are relatively open, but the EF is down. And so in this case, you could think, well, how would I proceed with this? If I'm going to do atherectomy, is the patient going to tolerate it? Well, because the EF is down and there's some diffuse disease on the left side, you actually can be well informed by doing a right heart catheterization. And in doing so, found something pretty striking. The wedge is up a little bit, the PA pressures are elevated, systolic blood pressure is kind of borderline, and the index is 1.4. There's poor peripheral vasculature for access. And so the question is do you feel safe proceeding with the PCI? It's just an RCA, right? What's the big deal? Well, the big deal is the patient is decompensated at baseline. And it's not so simple as just throwing a hemodynamic support device to overcome that because the patient has poor vascular access. So what support is needed to help a patient like this? The easiest form of support is actually to diurese the patient and to optimize them. And so instead of just plunging into the PCI, this patient came off the table, went to the floor, and after diuresis, these are the repeat numbers. The index is still low, but the rest of the numbers are far better. And with grafts open and some diffuse disease on the left side, we were able to do this case without any hemodynamic support at all. And that avoided the vascular complications that could have persisted, especially because she had poor peripheral vasculature to start off with. So there are situations, though, where you might think about prophylactic mechanical circulatory support. And why would we think about it? Well, number one is in some of our sickest patients, it's going to maintain blood pressure and oxygen delivery in some cases. It's going to facilitate more complete treatment. We're not going to cut corners. We're not just going to go get in and get out. We're going to do a good job. We're going to use imaging guidance and that sort of thing. And patients need to be able to tolerate the stress of the procedure. But we also need to make it safe, easier to use, and with an ability to minimize complications. For me, one of the key things that I don't like to use is the term called protected PCI, because for me, if you're doing a device, putting a device in the patient that doesn't benefit from it and exposes to him a risk of vascular complications, how could you interpret that as protective? It's not. It's actually gratuitous in that case. Maybe you're doing it for yourself, but it still is an issue for many of our patients. And so I like to call it PCI with hemodynamic support and hopefully judicious use of hemodynamic support for the right patients. There are data that show that hemodynamic support during high-risk PCI can be beneficial. In the original CHIP BESIS-1 study, actually it wasn't called CHIP then, it was just BESIS-1, one of the key endpoints of the study, which is a secondary endpoint, the overall endpoints were negative, but a key secondary endpoint was the incidence of procedural complications such as prolonged hypotension, VT-VF requiring defibrillation, and CPR requiring ventilation. That was dramatically reduced by upfront use of a hemodynamic support device, in this case, a balloon pump. So those patients were protected in a sense. There was a greater risk of bleeding overall, and so it had to be mitigated by that. But this is important data, and that's compared to a placebo. Now, why do we need hemodynamic support? The reason is fundamental, and that is that patients get worse during the procedures we do before they get better. The surgeons know this really well. That's why many surgeons, for high-risk patients, they just turn down the patient altogether because they know the patient's not going to tolerate what they do. Now, our insults are typically less than that of bypass surgery, but one of the most striking features from the PROTECT 2 trial, and this was a randomized trial of Impella and balloon pump, was that in both groups, the cardiac power output, which is the product of the cardiac output in the map, goes down because patients get sicker before they get better. And in this case, with a more supportive device, in this case, Impella, the degree to which they got sick was tempered because the device was more powerful and more supportive. But it wasn't needed in everybody because in those patients that had less revascularization done within that trial, the outcomes were really similar with both devices. It was just those in which more extensive revascularization was done with a greater insult that this more supportive device tended to be more of benefit than a less supportive device. So here's an example of a case of this. And this is a case that was actually in that trial, 90% LAD, there's diffuse disease on the left, the EF is down, the patient presented with a non-STEMI. And what happened in this particular case is that it was very hard to wire the circ and the diag. And what ended up happening is lost flow. And so you can see there's slow flow in the LAD, there's slow flow in the circ and the diag. The patient had chest pain and the systolic blood pressure dropped. This patient was on support, and what you'll see is that from the tracings is that the PA pressures go up. He's got ST elevations here. The pulse pressure narrows, but the map is maintained. So that is what a support device in its idealized construct does in terms of preventing the patients from getting worse while you quickly can fix the situation itself. Now, the challenge is that if we look at the more recent randomized data in this regard, and this is CHIP BESIS-3, which was just presented at the ACC and published in the New England Journal, this took a very high-risk population of patients, really sick patients, and basically randomized them to the use of an Impella device versus placebo. And what was seen within this trial, somewhat surprisingly, is that there was actually not a benefit to using the device up front, and there were more wins in this win ratio for standard of care. But one of the nice things that's been elucidated from this analysis is that there were differences in terms of the way the patients were treated when they had the more supportive device in the sense that more complete and extensive revascularization was done, and that was associated with a greater incidence of paraprocedural MI and even cardiovascular death. So the idea here is sometimes you might feel unfettered because you have the device in and have a tendency to treat everything you can, use a lot of atherectomy, do whatever you can because the patient is quote unquote protected. But the reality is that might be a false sense of security that you have. And in this study, sub-study that was presented at EuroPCR from a smaller segment of patients within the trial, what you see, interestingly, is a greater loss of pulse pressure among patients randomized to Impella, suggesting that the operators did a lot more in that group than they did in the non-Impella group. And that was also borne out by when they looked at their analysis of staging. Ultimately, when patients got staged in the other arm because patients and the physician stopped earlier in the procedures and then brought the patient back for the rest, the degree of revascularization was similar, but it didn't all have to be done at the same phase. So where are we left with this? Well, we don't want to throw out the baby with the bathwater. There's clear data that in specific populations like shock populations, that microaxial flow pumps actually can save lives. So dangerous shock showed that pretty well, albeit at a slightly greater risk of vascular complications and the like that was also seen within the trial. So what do I do? As I said, I don't call it protected PCI. What I do is I examine the patient, I do a right heart cath, I integrate the hemodynamics, what I'm going to do during the procedure, the EF, and managing the vascular risks to actually fully protect the patient and use these devices in the right patients, not in somebody, for instance, that I didn't look at the echo and had an LV clot. I'll conclude with one last case before I actually tell you a little bit about Protect 4. And this is the data that we're hotly anticipating. This will hopefully be next year. And the idea in this study is it's a much larger series of patients. I don't think we're going to see the mortality disadvantage that we saw in CHIP BESIS 3, because if so, the DSMB would have stopped the study, and they didn't. So I think we're going to get a more robust sample size to be able to identify, is there truly a benefit and which patients truly benefit from these devices in high-risk PCI. The final case I'll show you is one that shows you clearly there are cases where you need support. And this is a patient who had an EF of 20%, aortic valve area of 1, and an occluded RCA, transferred to our surgical service for AVR and CABG. While on the floor, developed chest pain and actually had this. Starting like with that with the first case, I have another example of it here, VF, VTVF. And actually got called by the surgeon, who had then taken the patient, cannulated the patient at bedside, unsuccessfully defibrillated the patient, but called me and said, the patient is actually moving to pain. And can you take the patient to the cath lab? Now, I don't think any one of us wants to take this patient to the cath lab actively fibrillating on ECMO, but our surgical colleagues and I worked really close together. And the idea here was the patient was actually moving and responding to pain, even though they were fibrillating. So we said, sure, we'll take the patient to the cath lab. This is the example of what you see. The heart is fibrillating. It's not really beating. And we didn't want to defibrillate the patient because we knew the left main had gone down. And so the idea here was to wire this while the patient's on ECMO and fibrillating. And after wiring and ballooning, this is the wiring of the LAD, we then were able to balloon the left main. And then we defibrillated the patient because now we have flow. The reason this patient went down is because the left main was completely occluded and the right was completely occluded as well. Turns out that we were able to successfully stent this left main both into the circ and the LAD. And remarkably, the patient actually survived with a full neurologic recovery after this procedure. And the concept here is that the pump is bad. And when the pump is bad, you need to support the pump and then do the rest as needed to help the patient. So for me, opportunities and challenges ahead in this space are that we need to address this high yield unmet need, patients with shock for sure. And we need to potentially think about expanded patient eligibility, but in doing so, have to really, really mitigate the risk of these types of procedures and devices. Complication management is paramount, and we have to generate evidence in a heterogeneous population, also taking into account the cost. But in the end, if we generate the evidence and move from proof of concepts to randomized trials and then real world evidence, derivate the sort of derived benefit for patients, then we'll be helping people. And hopefully we can open some time for discussion on this concept and some of the other things that we'll be discussing as well later. My voice held up, so let's go to a discussion at this point in time. And we have a great panel here with us today. And maybe, I know Barbara's going to give the next talk. So maybe, Sunil, I'll start with you. You're responsible for overseeing the guidelines and where all this data inputs into clinical practice. I think you're also really thoughtful about understanding there's a difference between trials and what happens in the clinic and what happens when people are actually taking care of patients. How do you put this together? I mean, do you agree with my concept that I mentioned about it's not protective if it's just, doing it for your own sake, but at the same time, how do we not throw the baby out with the bathwater?
Yeah. So first of all, I want to tell you it was an amazing, amazing presentation, really terrific, because I think it really underscores the fact that it is difficult to apply sort of broad swaths of recommendations to these specific clinical scenarios. I mean, we always talk about how every PCI is different, right? But I think you really nicely outlined how it's not just about the coronary anatomy, it's about the overall patient status, the hemodynamic status, and there are alternatives to try to optimize the patient's hemodynamics before you bring them to the cath lab. And I think that's a really, really important message. So I agree with everything that you said. I think that there is a role for mechanical circulatory support to reduce procedural complications. There is clearly a role for mechanical circulatory support to improve long-term outcomes, and that generally, the sicker the patient, the more the benefit. But there's also a role for, sort of knowing when not to use MCS. And I think you have to have the appropriate amount of information before you make that decision. And I think hemodynamics can be very, very helpful in that particular setting.
Well, thanks for that summary and for your kind comments. Nadia, any thoughts on this? You've practiced in a bunch of different environments. Does it vary based upon the institution? I almost feel that in our cath lab with our super experienced nurses and everything, I probably have a better safety net without the device. But in other labs where it's really just you and the staff maybe less experienced, maybe the device is actually important or more important under those settings. Any thoughts on that variability?
Yes, I definitely think that the cath lab experience and the operator experience and the number of years an operator has been practicing factor into the decision making. I think that also, the culture of the cath lab and ultimately tolerance for vascular complications and how those are dealt with also factor into the equation. There are some places where balloon pumps are still used in some circumstances. Obviously, there's going to be anatomic reasons why that might be the case sometimes, but I think that the more that we're familiar with the literature and have some of these conversations outside of the acute setting, it's really important for patient care because ultimately, sometimes we're making decisions over whether or not to use a mechanical support device in a matter of a minute or two, and so ultimately, getting familiar with the literature that's out there and the expected complication rate and those kinds of things, and getting to understand that is ultimately part of the risk benefit ratio for a patient. It all kind of melds together and, and equates into our decision for the patient. So that was kind of a long-winded answer, but yes, absolutely all of those things.
Ajay, I will say that.
Yeah. Go ahead, Steve.
Yeah, I will say that I think that the point that you and Nadia are bringing up is really important because the decision point in my mind is not limited to whether or not to use MCS. It's also to think about the next step. Does it need to stay in after the PCI? And if it's going to stay in, who's going to care for that patient? So that all has to sort of factor into that. Are you paying attention to the vascular access site? What is the plan for weaning the MCS? All of that, I think, has to go into these decisions.
No, great point. And Alex, I know you've thought long and hard about this, and actually, I think I've heard you give many talks where you this whole construct of being a better doctor, not just being the technical person in the cath lab, is something that resonates a lot with you. And I've heard you talk about it. Any thoughts on how this goes overall for you? You may be on mute. Or frozen. If we can't recover it, what we'll do is we'll move on to Barbara and have him give us talk, maybe give some thoughts before you lead into your talk. But I think you're going to talk to us about a semi-case complicated by cardiogenic shock, which is, I think, a great way of thinking about support, especially in patients that have ventricles that are at risk up front. So I'll hand it over to you. And if you have any other thoughts, just feel free to jump in with those two.
Yeah, no, sounds great. Just to kind of wrap up, I think on the complex PCI standpoint, I think, one of the humbling things that we learned from BSIS that I think many of us appreciated as we were doing clinical cases that I think is important to mention, and that you alluded to as well, Ajay, is that this concept of protected PCI is really something that really needs to be re-examined. I think, it's a terminology that I personally also kind of shied away from. When we're doing complex PCI that requires potentially the use of hemodynamic support, it's really important to keep in mind that you have to continue to limit your decision making on how much revascularization is appropriate for one setting. If you're utilizing hemodynamic support, it is really important to keep in mind what your goals and objectives are for the short term as well as for the long term. So maybe we can talk about that a little bit more. Let me talk a little bit about cardiogenic shock, and I'll do this with the use of a case example. So this is a case that we did from about 1 month ago that was included in the OASIS prospective registry, retrospective registry, and it's a STEMI that is complicated by cardiogenic shock. These are my disclosures. So this is a 61-year-old patient who has regular risk factors of diabetes, hypertension, hyperlipidemia. He's a smoker. He presented to one of our satellite emergency rooms with chest pain that began in the morning with shortness of breath. Now, this intervention was actually not done until the late afternoon, early evening. So the patient, unfortunately, was likely experiencing myocardial infarction for over 6 hours. When he presented to the emergency department, he had an anterior STEMI with a right bundle branch block noted on his EKG. Unfortunately, the patient had an episode where he became unresponsive, had VTAC, was defibrillated once, underwent CPR, and underwent about 4 minutes of resuscitation. However, luckily for the patient, when he woke up, when he was resuscitated and achieved ROSC, he was answering questions appropriately. He was immediately transferred to our center. That transfer process was under an hour. It was around 45 minutes. And he actually presented to the our cath lab originally not on any vasopressors, with a blood pressure of around 120 systolic. However, throughout the initial 15 minutes or so of prepping the patient's blood pressure was slowly going down and was around 105 prior to the diagnostic catheterization. The EDP was checked and it was 22. We started with images of the right coronary artery, and you can see that there's moderate plaque within the mid-segment of the vessel, but clearly a patent blood vessel, and without any major significant obstructive disease. The decision was made to go directly with the guide because of the anterior STEMI presentation, and what you can see is minimal disease within the circumflex at the top of your screen, and clearly an occluded thrombotic prox LAD occlusion. Very standard, I think, from a STEMI standpoint, with the patient's original presentation. So they used a 2.5 by 12 or 15 millimeter balloon. Did just a little bit of PTCA in the proximal segment, dotted that balloon, and on the right-hand side of the screen, you can see that there is flow that's being established. Unfortunately, during this time with the reperfusion injuries, which is a very common time for this to occur, the patient underwent a cardiac arrest on the table with support in place, and he arrested for approximately 10 minutes. And so this is something that's really important. During this period of time, ECMO was potentially going to be utilized in this setting, but luckily ROSC was achieved, and the patient was continued in regards to his intervention. We then moved on to doing intravascular ultrasound and evaluated the blood vessel, saw that there was a lot of thrombotic debris within the LAD, and decided to direct stent using a 3.5 by 38 millimeter drug-eluting stent. This was done on cangrelor, and I think that's an important aspect to consider. The DAPT AMI shock study that was presented at the ESC in 2025, but is yet to be published, demonstrated in the per protocol treated group that there was reduction in MACE outcomes in patients who presented in AMI cardiogenic shock with the use of IV antiplatelet agent, because, and hypothesized because of the rapid onset of action, which was shown in a pharmacological study, or part of the study within the DAPT AMI shock trial as well. But despite that, you can still see a very significant amount of thrombus burden, and you can see that the distal LAD, where that thrombus likely embolized, is still occluded. So this is on the left-hand side of your screen is a microcatheter delivering vasodilators. In specific, this was nifedipine and nicardipine that were being given, not utilization of epinephrine. On the right-hand side of the screen, you can see that a balloon was used to daughter the blood vessel as well, distally as well, with some minor PTCA. A distal injection was then performed, and you can see a little bit of thrombus that remains within the distal LAD that was underwent some further mild angioplasty. And then what you see in total is an open LAD with TIMI-2 flow. And so this patient clearly presented late. He presented in shock. He had 2 cardiac arrests, and he is on an Impella CP. And I think the question here now is how are we going to optimize this patient to be able to try to get the best outcome for this patient going forward? And I think there's a few important things to keep in mind. Anytime we're using large bore MCS devices, there is a significant risk of complications that will mitigate any benefit you get from a hemodynamic standpoint. And it's really, really important for operators to mitigate those risks to the best of their abilities. And so in this case, this is an angiogram that you can see that shows the patient basically has an obstructive limb. You can see some mild flow within the profunda, but really no flow within the SFA. So this patient underwent a distal reperfusion catheter with the Impella in the primary procedure. And then most importantly, similar to Ajay's point in complex PCI, in shock, hemodynamics are extremely imperative to guide your decision-making, because those are going to change before the clinical nuances of the patient may change as it relates to urine output or creatinine or even lactate measurements. And so a right heart cath was done pre-PCI that I didn't mention. It showed an RA pressure of 14, a PA pressure of 34/20 with a mean of 26, a wedge of 22, a PA SAT of 62%. And this was now on Impella, a cardiac output of 2.9 with an index of around 1.9 and a heart rate of 110. After revascularization, the delivery of vasodilators, the patient's blood pressure was around 94/67 with a MAP of 76. The patient was at this point on moderate doses of norepinephrine. The PA pressure was 66, and the cardiac output had improved to 3.4 with an index of 2.2. Now, this gave him a borderline cardiac power of around 0.6 and a heart rate of 100. Now, this patient had some particular demographics that are important to mention. He was actually 4'11" and around 60 kilograms. And so the body mass was clearly on the lower end. And so we felt here that an Impella CP should probably provide enough hemodynamic support for this patient over the next 24 hours now that he was revascularized. The things that went against that decision-making were that he presented with a late presenting myocardial infarction. So all things that we're trying to keep in mind as we're making our decision. However, the early hemodynamics improved a little bit. The PA saturation went from 66% from 62%. This improved his index a little bit. His heart rate was coming down, and so we were hopeful that this trend would continue. So we decided to bring him into the ICU, but to bring him in with a very low threshold of potentially escalating the patient's hemodynamic support. So we brought the patient to the ICU. We conducted a multidisciplinary discussion. We had our cardiothoracic surgeons on board for a potential discussion of an Impella 5.5 placement. However, the surgeons did let us know that in their minds, they felt that the patient's smaller body habitus would preclude this. And so there are mixed things that happened in this patient. And I wanted to present this case because I think that, it's very easy for us to make decisions when everything's going in the bad direction or everything's going in a good direction. But in this case, the patient's lactate was slowly coming down from 6.6 to 5.8, went up to a little bit to 6.3, and then was around 4.0. The PA saturation, unfortunately, continued to go down, 71 to 59 to 56. The pressors were also changed a little bit. The patient presented with moderate doses of Levophed, In the cath lab, that was changed after the procedure to low-dose Levophed, eventually stopped actually, with low doses of epinephrine and dobutamine to give the patient a little bit of support from a right ventricular standpoint. The patient's pulmonary artery pressure over the course of the next 4 hours was essentially the same. You can see the numbers here, 29/17, 4 hours later, 27/17. So they're not rising from a congestion standpoint. But unfortunately for this patient, over those same 4 hours, the vasopressor requirements increased significantly. So the dobutamine dose was at 5 mics, the epinephrine dose was around 4 mics, but the norepinephrine dose, which was originally stopped, was actually at the end of the 4 hours around 30 mics. And so we felt that this patient was deteriorating from the hemodynamic standpoint. And so with this mixed picture, even with the lactate coming down, do you potentially consider escalating this patient? Well, he was very young, very minimal comorbidities without any significant long-term concerns. And so we decided, because of the increasing vasopressor requirements requiring 3 pressors, 1 high-dose vasopressor, that it was probably worthwhile to consider hemodynamic support escalation. And so we took the patient back to the cath lab right around the 6-hour mark and introduced ECMO along with the Impella, as he was not a great candidate for an Impella 5.5. One thing that I wanted to bring up, clearly all of us know that the door to unload trial was a neutral trial, did not show any benefit of reduced infarct size with the use of an Impella CP in patients with anterior STEMI. And the patient population in that trial was without shock. But one thing that actually was really interesting to me that was demonstrated in some of the supplemental analysis was the problem of a large infarct is really important and not discussed a lot in cardiogenic shock. And so this is infarct size within the DTU trial. And what I'll highlight to you is this last box here on the complete right-hand side of your screen. There were 6 patients included in DTU that were danger-like. That means they presented with AMI cardiogenic shock that was unrecognized and therefore included within the trial. But look at the infarct size in those patients, 43%. I mean, these patients that present in shock have significantly large infarcts, and it's an area where we still need to research different therapies and different mechanisms to be able to improve outcomes. We all know that there's data to support potentially the use of something like supersaturated oxygen. This patient presented, I think, with a longer window of an MI, greater than 6 hours. He may not have been necessarily the greatest candidate for that. He was already treated with an IV antiplatelet agent, which may help in that way as well. But clearly, we need to do something more to be able to help these types of patients. And so what happened with this patient is, as you can see, on the left-hand side is the patient's admission echo, and on the right-hand side is their echo during hemodynamic support weaning on day 8. And you can see that there's actually very little difference in this patient's ejection fraction. The patient, unfortunately, did not recover his LV function despite revascularization and the early use of hemodynamic support with ECMO and Impella, and because of the likely large infarct that he occurred. And so what happened was on day 8, the patient unfortunately never really recovered neurologically. He unfortunately had a seizure on day 3. There was concerns of anoxic brain injury, despite the fact that it was a witnessed arrest on the cath lab table that was 8 minutes long. The patient never really had any significant neurological recovery. There were significant complications with the ECPella system where he was bleeding. He underwent 8 blood transfusions in total over that course and period of time. And he was not, unfortunately, a candidate for a durable LVAD or transplant either, because of poor social support and other factors as well. And so we ultimately elected to decannulate the patient in the cath lab and remove the ECMO. And unfortunately, this patient passed away the following day on the Impella CP with worsening congestion and increasing requirements of vasopressor support without a good long-term end game or prognosis for this patient. And so what went well within this case? Well, we were able to promptly deliver revascularizations. We used an IV antiplatelet agent that may be of benefit to such patients. We did hemodynamic guided decision making. We promptly took care of the limb perfusion concerns that were there. He underwent prompt, in my opinion, MCS escalation. I think the decision not to escalate the patient in the original intervention was very reasonable. Patient never actually required dialysis, but unfortunately, this is always the story in shock. There's more than just always the great outcomes, and I wanted to present you a real case of where you can do things in the right way but still get a poor outcome. And this patient had a delayed presentation, which in my opinion is likely the most important factor in why he did not do well, but also the second cardiac arrest likely led to some neurological injuries. He had complications with the MCS device, which is extremely common within the shock scenario. And so these are really important things for us to discuss and talk about, and hopefully we'll be able to do it within the panel. But I just want to leave you with the fact that even though we've made significant strides within the cardiogenic shock space, we still have a lot of work to do. And I think it's really important for us to focus in on this going forward. So thank you so much, and I look forward to the discussion.
Well, Barbara, thanks so much for that. I mean, it's pretty courageous to be able to describe a case like that, but I think if we're reflective, it's often more instructive to present cases that are real world like that, where despite everything you do that is evidence driven and thoughtful and everything else, sometimes the outcomes just show us that we still need so much more to do. In the interest of time, I think we need to move on. And so what I'm going to do is jump to Nadia, and we can probably come back at the end for any discussions on the collective presentations that are being made. So I think Nadia is going to talk to us a little bit about how contemporary practice has changed the environment for microaxial flow pumps. So really looking forward to this presentation.
All right. Thank you so much for the introduction. And I think that my presentation will actually echo some of the themes that have already been discussed. So I think this will hopefully kind of cement some of the themes that we've talked about here in my disclosures. So I wanted to talk a little bit about some of the clinical factors and considerations that I think about when approaching a patient in considering the need for hemodynamic support around PCI, touch on some potentially useful algorithms and guides, or at least get an idea of what's out there, talk a little bit about the idea of prophylactic use versus rescue use of hemodynamic support, a case example, and then just cover some best practices. So I'll just launch into this. So this is a list of all of the things that I kind of sat down and thought about, what are some of the things that I think about when I'm thinking about whether or not a patient should have hemodynamic support around the time of a PCI. And this is not AI generated, I'm proud to say. I just kind of thought off the top of my head, what are some of the things that I think about? And I think, some of the first and most important thing is probably the risk benefit of performing PCI at all. And then, as we kind of think about, yes, we think that this is something that's going to be helpful for the patient. The next consideration I thought is anatomy, which again, this is probably something you all have already thought about. But then the other things are things like vascular access, because that's a potential complication of using large bore access. To me, that is a big factor in the decision. If it's a small person with small blood vessels or somebody who's already high bleeding risk, then that also is taken into consideration. Then, of course, their hemodynamic need for the support device, as well as other types of clinical factors, including the age of the patient, if they have baseline anemia. Sometimes we have patients that are not willing to accept blood transfusions, other medical comorbidities. And then there's all of the other things that we kind of touched on earlier, but I think are really important in terms of, okay, what's the experience level of the physician as well as the lab staff? And actually, the physician experience level can go one of two ways. I mean, in some cases, if it's a patient who has concerning anatomy and, the operator would feel more comfortable because, for one reason or another, having the hemodynamic support, then, they may elect to use it in one circumstance that another operator does not elect to use it. And I don't think that there's necessarily a right or wrong, so much as, one operator may feel more adept at quickly inserting a device as a bailout versus another operator. It also is a consideration over whether or not you think that this will be a more complex procedure in terms of a need for atherectomy. What are the cath lab resources? The location of the procedure, is this a place that has cardiac surgery backup? Do they not have cardiac surgery backup? What is the comfort level of those in the lab, depending on the volume of complex PCI, the possible need for anesthesia, and then also whether or not there's a place for the patient to go afterwards. What is the level of ICU level support that can be provided, as well as the cath lab culture. There are some places that are more sort of favoring of hemodynamic support devices versus others. And I think that also plays a role in terms of the decision making. It's you could argue that it shouldn't make a difference, and that we should be standard in our approach. But I do think it does factor into some decision making. So I wanted to just highlight that there were a couple of different documents not that long ago, but seems kind of like ancient history, 2015. I think that this points to how far we've progressed even in the last 10 or so years. As I was looking back at this document, and there were sort of suggested indications for percutaneous mechanical circulatory support, all very valid reasons, but not with a level of sort of detail and I think thoughtfulness that came subsequent. Thanks, very much to many of those on the panel and presenting today, because I think you all have made major contributions to the field, as evidenced by this document, which came not that much longer, but really broke down into pieces. Okay, so what are the types of patients we should be thinking about the use of mechanical circulatory support in? What are some of the clinical factors that we should be looking at? And I think that I'm sorry if the text is a little bit small, but I think that as we're thinking through in our shock teams, reasons to select one device versus another, or whether or not to pursue hemodynamic support, these documents can be useful to lean on, especially as you're developing documents for shock teams and those kinds of things. I think that they also give us other clinical factors to think about that we might not have thought about without having a document such as this to guide us. But ultimately, I think that all of this work in the field together has led us to a place now where I think we can make much better decisions for our patients than we were able to about 10 years ago. A few years ago, we had this SCI clinical expert consensus statement on the classification of cardiogenic shock, which also discussed the use of support devices for patients in cardiogenic shock. One thing that's kind of interesting is that while some of the other guidance will give us sort of clinical factors to consider in whether or not we select to use a support device for a patient, interestingly, in our SCI shock classification, whether or not we decide to use a support device or not is actually part of the algorithm for determining this patient's stage of shock, which is kind of interesting that we are kind of a factor in how things get categorized, and our decision making actually is important to classifying the patient's degree of illness. And I think that comes back to the fact that we all do have some clinical gestalt, and there is some art to medicine. There have been a couple of studies that looked at observational studies that looked at prophylactic versus rescue use of mechanical circulatory support. I think that, again, with PROTECT 4 coming out hopefully in the near future, we'll get some more interesting information from that study. But ultimately, some of these questions are maybe will never exactly be answered by a randomized clinical trial. So we have to rely on observational studies with the caveats that go along with them. But ultimately, both this study, which was a multi-center study from Europe, noted that there was a significant reduction in death for patients who had a mechanical support device placed before they underwent a high-risk percutaneous coronary intervention in sort of a semi-elective or non-emergent fashion. And then also this study out of Michigan, which is also another multi-institution study, looked at bailout percutaneous assist device versus prophylactic strategy in patients undergoing non-emergent percutaneous coronary intervention, and similarly found reduced risk of MACE in patients who had sort of a preemptive or a proactive approach versus those undergoing a bailout strategy. So I would like to just move on with the case, and maybe I wouldn't say it was out of necessarily laziness. I think this was actually an interesting case, but it just happens to be the last case I did with mechanical circulatory support not too long ago. But this was a 53-year-old woman who had a history of neurogenic orthostatic hypotension, fibromyalgia, hypothyroidism, migraines, and a prior gastric sleeve with Sjogren's and asthma, who was actually admitted to the hospital and had been in the hospital for about a week with mostly recurrent syncopal events, but was also complaining of chest pain, for which she'd actually undergone a nuclear stress test just a couple of days prior as an inpatient, which had not shown any ischemia. She had had an autonomics consult, and medical therapy was being titrated for her syncope, including things like midodrine. She developed the acute onset of severe chest pain. As you can see on her EKG here, she had anterior ST elevations and sort of some reciprocal depression in the inferior leads. And, whenever I see that wavy baseline of the EKG, it always catches my attention, because to me that suggests the patient was probably breathing heavily or moving and probably in distress based off of the EKG. So we started with radial access and took a picture of her right coronary, and you can see that there was already some collateral filling there at the end of the image to what looked like the proximal LAD. And given the patient's history, we were it was already on our mind that the patient may have had a SCAD event. So this next image is a fluorosave. It's the only image we took before stopping taking pictures. So we had gone up with a guide and noted that the left main was occluded. There did seem to be perhaps a little bit of a double density there. We were concerned for SCAD. At this point, we thought this patient was going to need hemodynamic support, and I took a couple quick tests with a wire, and it didn't seem to want to go freely. So we switched gears very quickly, probably within about a minute, and started working on getting femoral access on the left-hand side for hemodynamic support, and simultaneously began actually calling our colleagues who placed our ECMO cannula as well. So at this point, I had the luxury this day of working with a fellow, and so we were able to simultaneously get access for ECMO as well as for an Impella. And part of the reasoning there was that I was a little bit concerned at that time. I didn't know how long it was going to take to reestablish flow. And in the event that the patient would need more support than an Impella, as she was not at this point in any kind of arrhythmia, that if it was headed that direction, that ultimately we should be prepared for augmenting her hemodynamic support beyond the Impella. So as you can see, this was our next picture. We got our Impella in, and it was fortuitous that my cardiac surgery colleagues who cannulate for ECMO were in-house, so we already had our access. They cannulated the patient for ECMO. She was at this point on pressors and intubated. We actually never did need to do CPR. There was at one point her blood pressure dropped as low as 60, but she was still talking to us, and she did not end up actually having any arrhythmias that required a cardioversion. But mostly the issue was hypotension and shock. So we, as you can see, there was a bit of flow, came back with a different guide catheter to hopefully come at the true lumen from a slightly different angle. And fortunately, we're able to wire down a direction that looked like it would probably be the LAD. And then our next step was to use IVUS to determine if we were in the true lumen or not. It's always a little bit nerve-wracking to run an IVUS down a vessel that you're not sure if you're in the true lumen or not, but that's what we did. And I didn't go all the way down the LAD, but as far as we went, we could tell that we were in the true lumen. And I think that in this case, having the hemodynamic support enabled us to do some of this intravascular imaging, which we might otherwise not have had the luxury of trying to do. Again, we were in the true lumen, so that was, great. But if we had not been in the true lumen, and if we had not had the hemodynamic support and stented in the false lumen, that might not have had the same outcome. So I thought these were pretty interesting images showing some of the areas where there was the false lumen, where there must have been blood, and then some of the other areas of the false lumen where there looked to be clot. And so ultimately, with that information, took a leap of faith and stented with a very long stent. Ultimately, we placed the beginning of the stent right at the very beginning of the left main. Based off of our IVUS images, we thought that would be needed. And there was a very slight stent edge residual dissection, which we covered with a second stent. Fortunately, we did not lose any side branches. We were able to see on our IVUS that, and after we had taken a slight puff, that our circumflex appeared to be open, which we were very grateful for as well. And ultimately, we did a slight repositioning of the impella and actually transferred her to the ICU with a swan in place. Because she had a ECMO circuit, she did not have elevated pressures. Ultimately, like, her PA pressure was less than 10. What ended up happening with this patient, subsequently, we just took some post-PCI IVUS images. She was decannulated from ECMO the following day, and then 2 days later, her impella was removed. She did have a follow-up. She had a mildly reduced ejection fraction at the time of discharge, which had improved to 45 to 50% at a hospital follow-up visit. She did end up with a small left femoral artery pseudoaneurysm, but we had taken a picture of the left femoral artery before inserting and doing some other steps, which I will cover for you here. Some of the best practices that I think we've covered to some degree so far, but it never hurts to kind of go back over them again. For our femoral access, we used ultrasound guidance. We used micropuncture. We took a femoral angiogram prior to insertion. We pre-closed. We did put a PA catheter in. We made sure that her MAPs were elevated enough using vasopressors as well as hemodynamic support, and subsequently were able to wean those. We did use a distal perfusion catheter, and she had, close critical care follow-up in the ICU, and we were subsequently able to wean her inotrops vasopressors. So I think that will probably conclude my presentation here. So, but I think ultimately, I hope I've covered for you some clinical factors and considerations, both like from an operator's perspective, as well as what some of our guidance from the literature says. I talked a little bit about prophylactic versus rescue, use of mechanical circulatory support, covered some useful algorithms and guides, a case example, and covered best practices. So thank you so much.
Anya, thanks so much for that. I think we're going to have to plunge on with the next presentation, but I think all these presentations show the amount of thought and attention to detail that's necessary. And so with that, I think Alex will talk to us a little bit about how you think through weaning and escalation and the like. So let's go to you, and then we'll come back to questions at the end.
Great, thank you. Yeah, I'll try and move through expeditiously, and luckily going last, I think a lot of things have already been said, and I'll be able to reiterate a lot of concepts. So I'm going to talk about best practices and pitfalls when using hemodynamic support for complex and high-risk PCI. Here are my disclosures. So I'll talk a little bit about planning, device selection, and that's yes, no, and what type, vascular considerations, the importance of hemodynamics, how to maintain focus, and then a bit on the post-procedure piece. So I think some of this all starts with counseling. So if you're deciding to do a high-risk PCI, complex PCI, use mechanical circulatory support, I think you have to, think what is the risk, what is the benefit I'm trying to achieve, and how does one relate to the other. So when you look at this data here, in these really high-risk cohorts, we sort of forget that you have double-digit risks here. And sometimes we have to think through patients and look at the relative risks and benefits. Maybe a patient is best served with medical therapy, PCI, surgery, or transplant. I think we've all seen the person with 10% EF that's getting an intervention to the OM6 with support, and really maybe that's not the right answer for that individual. This was well covered by you, Ajay, during your talk. Why consider MCS? So part of it is this concept of wanting to achieve complete revascularization, and some of it is just to provide a background of hemodynamic support and total body perfusion when that may be lost during the insults that we are delivering to the patients in the pursuit of good. So, this kind of covers a little bit about that. There's these pre-procedural optimization that is important as a best practice. There's procedural planning. There's this adaptive strategy during the procedure. So you have to have an ability to change gears when the situation changes. And then what do you do afterwards? And thinking through, what are you trying to achieve with high-risk PCI? What are you trying to prevent in terms of circulatory collapse or cardiac arrest? And prevent de-escalation or devolvement into cardiogenic shock. And this helps decide both, do you use circulatory support? What support do you use? And what is your overall procedural strategy as well? So I think there's so much we can do to optimize patients. Again, there was that example from the first presentation about diuresing a patient to make them a lower risk patient and obviate any need for mechanical circulatory support. And I think this is really often overlooked and underappreciated, but is really, really important strategy. I think, this was touched on too, is not just looking at the patient. So what is the proper revascularization plan? Where should this be done? How much time do we need to permit in the schedule? Really, is this, are all of these cases appropriate for every operator, every center? And that's something I think as an individual operator, as a team, as a hospital, you have to look in the mirror and decide, what is best for the patient and discuss with the patient. Planning is critical. That's, best practice. And some of this planning happens weeks, months, years before. Is your cath lab team, is your hospital, is your ICU, is your multidisciplinary heart team prepared to do these cases in a safe, effective manner? And do you have a track record of safety and success or not? And have you put in the time and effort to get better over time? And then immediately before the case, I always joke that we have performative timeouts when we talk in the cath lab about a fire risk, but we don't always do a timeout to really talk about what is our procedural strategy? What are the individual roles of the teammates? What challenges might we encounter and how are we going to address those? And that's critically important. And I'm not going to go over this whole slide, but this really, speaks to the preparation that you put in advance. Or do you recognize complications? Do you recognize potential pitfalls of the case? Have you prepared in advance? Do you have everybody on the lookout? And have you trained and rehearsed strategies to overcome these in the cath lab? Vascular considerations have been well covered. I think, we all know that vascular complications and bleeding complications, the rates of those far exceed any PCI-related complications, but we kind of tend to focus on the PCI-related complications. And this is really a major Achilles heel of any decision to look at large bore access with mechanical circulatory support. And again, this breaks down to patient-related factors, operator-related factors, procedural and anatomic. I have some references on the bottom, and one of those, that box.com link, is a little video of kind of a soup to nuts vascular access management, closure, and ICU management video that you can watch offline sometime. Hemodynamics was also appropriately reiterated. So the decision to use circulatory support, what type, and whether to take it out at the end of the case or not, really has to be driven by hemodynamics. And so for the most part, some is going to be, use of a SWAN. And again, the first presentation showed SWAN numbers that led to the decision to abort a case and postpone it in diurese patient. And I think this also gives you an early warning system during the procedure to decide, is something bad happening under the hood? Do you need to switch gears with your strategy, or do you need more support? And here's a brief summary. Then I'm just going to show two brief cases. I want to credit Sanjog Kalra. I borrowed this slide and kind of adapted a little bit. But some of this is identifying who are the patients that are a high-risk patient that are appropriate for PCI and in whom you might consider mechanical circulatory support, balancing the relative benefits versus the relative risks. Have they been evaluated by the multidisciplinary heart team? Are they better served by surgery, PCI, medication therapy, advanced heart failure interventions like VAD or transplant? Have you planned out your procedure as an individual, as a team? Have you thought through an adaptive strategy where you can move on the fly as conditions change in the cath lab? And are you using hemodynamics to wean or not wean the device post-procedure? And what is the aftercare going to look like in the cardiac intensive care unit for a lot of these patients? So I'm just going to show two quick cases, which are kind of on different parts of the spectrum, but I think important. This is a gentleman in his 50s, had bypass, early CABG failure, came in with acute coronary syndrome. EF was not severely depressed, 45 to 50%. Most people would say no need for circulatory support. I think I approached this. This was a person who had multi-vessel disease, had no CABG option, really had already been through a lot, and I wanted to make sure had complete revascularization, had a lot of calcium. We're going to focus on calcium modification and wanted to do the job right. So brought him to the cath lab, placed a PVAD intentionally up front, had a SWAN for hemodynamic management, and wired all three vessels and did a DK culotte intervention with calcium modification, and ultimately used hemodynamics to wean the PVAD off in the lab, and then moved on to guideline-directed medical therapy, and then ultimate discharge, and the patient did well. This next patient is very similar to a patient, interestingly, that Ajay showed in the beginning. So this was somebody that was in the ICU, came in with ACS, and was in borderline cardiogenic shock. On the way, wheeling him down to the cath lab, arrested. So brought him into the cath lab, put him on ECMO, basically ECPR situation. Was in refractory VF, placed in Impella for venting, a lot of pharmacology, and also ultimately after all that still required double sequential defibrillation to get this gentleman out of shock. Cooled off, had a multidisciplinary evaluation with surgery, heart failure, about options, switched over from the CP to the 5.5, and then it was decided as a group to bring him back to the cath lab. So I brought him back, stented left main into LAD, across the LAD occlusion. The circumflex CTO opened with antegrade techniques and just left that a balloon angioplasty only result, and then used that now open circumflex to come retrograde to open the RCA, again, looking at complete revascularization for this gentleman. Again, another gentleman, late 50s, early 60s, had a long, complicated course, ultimately recovered, went home to his 3 teenage kids, and back to work full-time. So 2 very different cases that may show different reasons for circulatory support use. And I'll sort of leave you with this. I don't know what the answers are, and I always get a little frustrated when you kind of hear the loud voices on either side about everybody needs support or nobody needs support, and this balance between therapeutic nihilism and irrational, exuberance. And I think as clinicians, we're going to realize the truth lays somewhere in between at all times. So in conclusion, I think in approaching these cases, when I think about best practices, assessing your goals, knowing what your track record, your team and your center track record is with risks and benefits of a procedure, particularly vis-a-vis use or non-use of circulatory support, optimize your patient before, because that may obviate any need for hemodynamic support. Plan your procedure, use your hemodynamics to both pre, peri, and post-procedure. And then I think in the end, we all have to live with some uncertainty, but as we gather more data and more experience, hopefully we can all adapt, evolve, improve, and make things better for our patients over time. Thank you.
Well, thanks so much for that, Alex. I think all of these presentations have been really, really important. And I think one thing that's happened after the ACC is that you just see a degree of thoughtfulness and nuance in all of these presentations that probably represents what people were doing in clinical practice, but you rarely kind of saw on podiums. So kudos to all of you for those talks, for those thoughts. We do have to wrap up soon. So maybe I'll just sort of, go around once for some take-home messages. Maybe start with you, Sunil, and then we'll go through Bob or Nadia, and then Alex last. Go ahead, Sunil.
Yeah, thanks, Ajay. I just want to compliment everyone's talks. Really fantastic. To me, the take-home message is really about individualizing care. I think that's really, really important. I mean, clinical trials are really important. We want to apply them at the bedside. Guidelines are important, but at the end of the day, you have to treat the patient in front of you, and individualizing that care and using as much information as you can, like the hemodynamics, like the left ventricular ejection fraction, and the overall clinical picture is really, I think, paramount to improving outcomes in high-risk PCI and shock.
Okay, go ahead, Bob.
Yeah, and I'll piggyback on that and say that, from my standpoint, I think, a hemodynamic support device can only improve hemodynamics. And I think that, the utilization of these devices in elective situations is never going to be something that actually improves hard outcomes, in my opinion. I think we need to be really judicious about its use, where hemodynamic support may be helpful in a routine fashion or a predominant fashion is really in those patients who have hemodynamic compromise, particularly those in cardiogenic shock. And I think we need to do a lot more system-based efforts to improve outcomes within those patients as well.
Yeah, and that gets to some of the questions in the chat where people were asking, is it the left main being unprotected or the EF? It's everything. It's everything together that sort of needs to be integrated into decision-making that can be individualized. Nadia, any final thoughts?
Yeah, I mean, the main thing I wanted to mention is just that I think that ultimately it can be very difficult to predict when a patient's going to come in shock. And so ultimately, this is a skill that we all need to have some baseline familiarity with so that we can be equipped and prepared to take care of patients when they come in sick and at all hours of the day. So even if it means that, there might be a case where you might be on the borderline for electively using a device or not using a device, but if it's been, a period of time and you haven't, gotten your hands on the device, it might be wise to consider actually using it just to make sure that you're maintaining a certain baseline skill level. So that would be my main advice to folks that hasn't been covered already.
That's great. There's a question that came in about how do you make the decision-making structured enough to guide the team, but flexible enough to change course? And that's exactly right. You have to have general guidelines and principles, but you have to communicate with members of your team, not just by text message, get on the phone, discuss, see the patient yourself, round together at the bedside, and be dynamic in the sense that you're going back. And Barbara's case was a good example of this. You go back and keep reassessing and changing things. Nadia, you showed this as well as time goes on, and that's how you manage individual patients. Alex, any take-homes from you?
I'm actually just going to reiterate what you just said. I said one of the great benefits and sort of privileges and enjoyments I had of doing, sort of getting more into high-risk PCI and mechanical circulatory support was building really strong personal and clinical relationships with my heart failure and cardiac surgery colleagues. And I think we really elevated a program because we learned so much about what the other one does. And we had a better appreciation for the menu options on the table for each patient and really worked together as a team to make these decisions. And that really had all kinds of spillover halo effects throughout the hospital and certainly for patient care across the spectrum.
I think that's great. And there's another question about common pitfalls when integrating microaxial flow devices, or any device for that matter. I think the biggest pitfall I see is that people sort of hang everything on the device. These devices are amazing, but the way that they're implemented through team-based structures and clinical decision-making probably impacts things more than the device itself. And so I think everybody learns that. There are benefits to them, or really dramatic benefits to them, but there are also really severe complications that can occur too. And so it's the integration of these devices and protocols into practice that ultimately is the essence of clinical care. And so with that, this has been a great session, and we're going to close it and thank all the discussants and participations, also the audience, for this session. And I'm just going to, say a few words, and we'll let everybody leave here to wrap up this day 2 of TIO 2026.